It works.
Cool.
My friend.
How's it going?
Guys, it's your boy Z-Dog MD, a.k.a. goes to Target and buys a NASA shirt. Dog. And I am really excited about today's episode. And just to preface it, I have Dr. Chris Weaver, a forensic clinical psychologist at Palo Alto University here in Palo Alto. And if you guys think, and this is his office, if you guys think that that's a painting, you better think again because that's real.
You can touch it.
Real. You can actually. In fact, look. Ooh, peel back the veneer. It's legit. So today I wanted to talk about, and hi Samantha Elizabeth, welcome to the show. And hi Courtney Adkins. It sounds like Romper Room, doesn't it?
Yeah.
And we got Courtney and Samantha, and I'm trying to talk like in my best psychologist voice. So Chris and I were talking the other day. Chris and I go way back, and we were talking about the Silent No More campaign on our show, and how we're talking about healthcare violence, violence against healthcare workers, et cetera. And I told him, one of the most common messages that I get is from healthcare people, psych nurses, other doctors saying, when are you going to talk about mental health? Like, you've had your mom on the show. Never, because nobody talks about mental health. We don't fund it. We don't talk about it. We don't properly treat it.
It's much easier that way.
Isn't it?
Yeah.
How much easier is it just to stigmatize the heck out of something, right? And then you're like, well, now I got to go see a psychologist, and they have weird beards and stuff. And why? I mean, why?
Nice
why?
offices, though.
Yeah, it's what we do. So we were talking about this, and we we're going, this is kind of his life's work, is how to destigmatize, decriminalize mental health issues. And he's been doing incredible work on the front lines. And he started telling me about it, and I was like, what? Stop.
Let's talk.
Don't tell me now. Tell me on the show, because the tribe needs to hear about this. So we're really excited. And here's Lori Tarter-Ewan, from a psych nurse from Fort Washington. Yeah. So already the crew has joined us. Now, what I wanted to do is I wanted to back up a second. So we're going to talk about issues around mental health, violence, how the police interface with the mentally ill, how our emergency departments interface with the mentally ill, how we could coordinate it all better, how we can actually put the emphasis on treatment instead of criminalization, treatment instead of jail, and good ways to think about de-escalation, preventing violence, and understanding that actually violence among the mentally ill is still quite rare. Yeah. So destigmatizing that as well. So Chris, maybe you can start by telling me, as I load up all this, what's your sort of background and training? Why'd you get into this? And why forensic psychology as opposed to sitting on a couch making a ton of money listening to rich people? Tell me about your mother. Exactly. Yeah. My mom is crazy.
Yeah, okay. Well, then you don't need me.
You guys have met her. Yeah, exactly.
So my background is basicly in, I grew up interested in sex offenders. So my interest was, yeah.
You can't make this stuff up. No, you can't make Please, continue.
Probably shouldn't talk about it on YouTube Live either, Facebook Live. So I was really kind of mostly interested in the way that folks make assessments of violence risk, and that involves a lot of work in sex offender risk assessment, because that's what we get real excited about. There's a guy at UCSF, Dale McNeil, who's still there, and his primary thing is saying, well, if we have all the ways that we do things in forensic psychology, because we're going to get challenged by the courts, so when we do things our certain way, we know there's always going to be somebody attacking our methods and things, and so our methods have evolved to handle that. And then, Dale's kind of asking, when we do this in psychiatry or in healthcare settings, why is it that it's a much less structured, much less rigorous kind of approach, and do these things that we do in forensic psychology, can they port over to primary care or to psychiatric care? And that was interesting to me, so that brought me out to UCSF. I thought I'd come out to California and spend a year or so with the crazy folks out here and get out of here as fast as I could. Fell in love with the place, and while I was there, a lot of my colleagues are actually experts in post-traumatic stress disorder. And, I'm looking at folks thinking this guy, guy walks in and looks psychopathic to me, freeloading off of friends, doing all this kind of stuff. And my friends are going no, go back and check. I bet there's a history of trauma. And I'm like, yeah, get out of here with that stuff. I don't need to hear all that, California hippie stuff.
Right, he's a psychopath.
Yeah, come on, he's a psychopath. Call it what it is, right?
Right.
And sure enough, I'd go back and more often than not, they were right about that. And then that was interesting to me. So the degree to which we kind of meld those two things was real interesting. And then it turns out that just a few miles south of us, the Veterans Hospitals maintain one of their primary offices for what they call the National Center for PTSD, and I'm going to give you guys links to those folks because they're a good connection for PTSD information. And really started working with them a lot there, and while postdocing there, I got a call from the police that said, hey, what's this PTSD thing? We think we could learn about that, and really kind of took off from there.
So really all the things we've kind of been talking about, so how does PTSD affect our veteran population? How does it affect the interface between the police and people suffering from mental illness?
Yeah.
How does it interface with healthcare providers in the front lines? And so Chris has been on the ground floor for all this stuff in San Francisco in particular, and working with police authorities around here as well.
Yeah,
right?
up and down the peninsula here, yeah.
Right, and you're originally from what, West Virginia?
West Virginia. Yeah.
West Virginia.
Representing any West Virginians, shout out there.
There it is, West Side. And let me know, by the way, if the sound is good. I realized I forgot to activate the mic, so hopefully the mic is working. I don't see any complaints about the sound. One question that already came up from Christy Columbus is, are you an MD or a PhD?
PhD, yeah, PhD clinical psychologist.
So we're getting an actual somebody who's on the front lines and also in the research community on this stuff. And so what interested me is when Chris was talking about how he works with police who are dealing with potentially violent people who aren't necessarily criminals per se, or not yet.
Yeah.
And they're about to be criminalized because they're about to do something either in an agitated way or a violent way or against a police officer, against property, something like that.
Yeah.
And how can police deal with that in a way that's different and more compassionate and more medically appropriate than criminalizing it and just beating them up and throwing them in jail?
Yeah, and one of the things that, two of the approaches or two of the key things that we're trying to get folks to do, and this is part of the broader kind of conversation about police nationally and what we're trying to, how we're trying to liaise with those folks and work together to kind of meld our expertise for a greater good. And a couple of the big pieces there are, one, just recognition of the mental health issues, which I think also pervades all the way up and down through the systems of care, including out to the outreach folks who we call police. And then once they're encountering somebody, are there techniques that we use in healthcare or in mental health care that are de-escalation techniques, and can any of those be useful to the officers as they're out there trying to work with folks? So those are the two kind of initial things to just kind of get a situation responded to, recognized, and calmed down. And then the next thing that we're kind of working on, and the we is the big royal we nationally, folks working with police, is getting them to think about options for referrals into the health and mental health care systems instead of a jail system, which is problematic from our perspective. And then we were talking about it, and I said, yeah, so I'm trying to get the police to bring all these folks over to the healthcare settings. And you said...
And the healthcare setting's like, no, because we're overflowing. How many of us work in emergency departments in county situations or even private situations where mental health patients are in the hallways waiting for placement?
Yeah.
And the police don't, when they bring them in, it's tough because we don't have the capacity, but then the police, their other option is what?
Is jail.
Take them to jail.
Take them to jail.
Now you're having a psychotic break, or you're in the throes of a manic episode, or you're having a PTSD episode, and you go to jail. That's possibly the worst possible outcome for that patient, for our system.
And, multiple generations of outcome, right, for that. So, now all of a sudden, for reasons that really flow from a mental illness, you're in jail. And then now you're not making, your commitments to your family. You're not making all this other stuff. And
everything falls apart. You said something in the beginning of this where you said you made this connection, it was made for you, that somebody who appears to be a psychopath or psychopathic, expressing these sort of traits of emotional deadening, impulsivity, all the other things that we now criminalize, right? May well have instead been a victim of trauma. It may be PTSD, it may be earlier trauma years ago, and they might look very similar.
Yeah, and that's what got me. I'm not necessarily, there are folks in my field who are just always interested in working with military vets and always interested in working with PTSD, and I wasn't one of those guys. And when I saw this PTSD connection, though, it's one of the things that looks like it's maybe one of the mental illnesses that's at the hub of this criminalization issue. We've talked about psychotic disorders for a long time, and I think that that's a disorder where the way that it manifests, everybody is willing to say, look, this is a break somewhere, this is not supposed to be working this way, this is real easy to link up to a medical model.
Yeah.
And then when we look at post-traumatic stress disorder, some of the folks, the way that some folks have their reaction to PTSD, it looks much more like something that we're actually willing to come away from a medical model and look at it as more like a criminalistic model. And that disorder is particularly interesting in that way, the way that it lends itself to that problem.
Yeah, and we got some comments already. Shannon Beatty says PTSD is not screened for enough. It's often misdiagnosed as bipolar. There's other misdiagnoses, right? You said psychopathy.
Well, and there's legitimate comorbidity all over the place. There's depression. I think we know that in healthcare settings and mental health care settings, anxiety disorders in general, where this used to be classified, are difficult to get caught. So that's an issue. I also, to that point, because I think he's spot on there. I want to leave you guys with a link to a screener. So I've got just a brief screener we can give out to your folks
for PTSD.
For PTSD, it's a 1-page, 5-item thing that's written up by the National Center for PTSD and given away free because it's government funded. So we can link that and start to tackle this right now. Yeah,
so we'll put that in the link after the fact and also on the web post and in the Facebook description and comments after we're done. So that's a great resource. And he has a few resources that we'll share throughout this. So Susie Fuller says, I'm an ER nurses all over the country. ER nurse here. So Susie's an ER nurse. And all over the country, there's never enough mental health providers outpatient, never enough inpatient units. So if you're trying to talk about recognizing what we think we're mixing up criminal behavior with a psychiatric diagnosis and trying to be compassionate and do the right thing for them. If we don't have the resources, like what?
Yeah, what do you do?
Yeah.
What can you do?
So how have you?
Yeah, I mean it's one of the things when we're looking at this from the intervention at the police stage, right? So it's one of the things that's the most challenging. In a place like the San Francisco Peninsula, we have resources. We have a lot of resources. We don't always have a lot of beds, but we have a lot of resources. And so a challenge can still pop up in a place like this because folks don't feel like they're suited to take referrals from police. So even in places that have resources available, this isn't necessarily syncing up yet. There are places, and I grew up in these places, where I think there was a social worker in the entire 100-mile radius of the place. So I think that the resources can be incredibly limited in these places. And one of the things that we've done locally and also nationally with our folks is, when the folks who we've seen have success with this is, for every time that you make a referral or can get something done, you record that and you report about that. And for every time that you try to make a referral and there's nothing there, you record that and you report about that. So let's start recording these things where I'd really like this kind of setting to send this person over to, and we can't, so sorry they went to the jail. So FYI, taxpayers, that when we think about if we want to fund this mental health stuff or not, here's the trade-off.
Here's the actual numbers, which, again, you're saying we don't have because it's underreported.
Yeah, I mean, well, that's screen. You have to know about it before we can talk about it.
Right, you have to know about it, and then some people are just going directly to jail, right?
Yeah.
And you showed me, it's interesting. So one of the other things that you do that I thought was fascinating, and I think this relates to our Silent No More campaign, we're talking about how do you de-escalate a violent person with a psychiatric comorbidity that's either active or even maybe isn't active. And you work with police to do this, but a lot of those principles can be also applied to frontline care providers in the emergency setting or in any setting. And you showed me some really interesting videos online about how police respond to psychiatric patients when it fails. So on the extreme, where the psychiatric patient maybe has decided they are going to commit suicide by cop, and so they 911 is called and they come running at them with a knife, and you see in the video they get shot. And that's one extreme where you could do everything right? They could be prepared, but it's still the patient is determined to take their own life and do it via another's hand.
Yeah.
But then everything in between is where it gets really interesting.
Yeah, before we can stop it before it gets to that point.
Right.
I think that's the key thing. So the de-escalation is a piece that, to be honest, I think that some of this is about kind of showing folks techniques that are maybe new to them, but so much of this is really just driving home best practices kind of stuff. And, I know, like one of the techniques that we teach, we call it tactical transparency for the police, but we say, that the general technique is before you start to do something with somebody, tell them that you're going to do it. And then that way you're not surprising people or shocking them, right? I mean, this is part
we tell our dentists
what everybody does.
Yeah,
right?
yeah.
We call it the good dentist technique. So the bad dentists out there, you should listen to this.
Right, I'm about to drill your tooth.
Yes.
Or you're going to feel a little pressure pressure, right?
Yeah, or this is the one with the rubber. You'll be okay. Let me spin your finger, right?
Right.
So yeah, so that's the that's the approach that we try to get them to take. It's common in the health and mental health care fields. It's real different from the way that folks think about tactics in police work, because they think that that's what gives them an advantage. That's how they're keeping the situation safe.
The secrecy around it.
Yeah.
So not telling the potential assailant, hey,
Yeah.
my partner's going to walk around you
Yeah.
to make sure everything's okay and you don't have a weapon. So understand there's going to be someone behind you.
Yep.
Right.
And for folks like me, that might work. I don't know police tactics, so they're probably fine not to tell me.
Right.
But for folks like military vets, and that's kind of how we approach them, is thinking about this for military vets. They know the tactics, so you don't have a tactical advantage. So are there times
They already know.
Yeah. But again, just enhancing this for our mental health and healthcare folks. This is stuff that we already do. But when we get busy in the day-to-day and just trying to rush through whatever list it is that we have to rush through in our work, we're figuring out and doing the math on what corners to cut. And the cutting of a corner like that is just much more important when I've got somebody with a mental health issue than it is that somebody just stressed for general life stuff.
And you brought up veterans in particular, and you spent some time at the Menlo Park VA.
Yeah.
Working with this population and the officers there. Anything you can say about that experience?
It's interesting. I've always grown up with family and friends in law enforcement. I've always been comfortable around that group. I'm a member of the mental health community, myself. So I'm someone who can see a lot of different perspectives on things, and those perspectives have nothing but diverged since then. So it's become even more and more like
polarized.
That. Yeah.
Black Lives Matter, Blue Lives Matter.
Yeah.
The police, everybody else.
Yeah.
Right.
So one of the pervasive themes has actually been we go to police officers and we see a lot of things skills that we can give them that'll help them do stuff. They don't even necessarily know what we can help them with, and we don't necessarily know that either. And then they will talk to us about problems they're having, interfacing and liaising with the mental health and the healthcare folks. And there are just a lot of, I think, miscommunications that we can probably use to kind of tackle this thing a little bit if we could get into more collaborative work together. But there's some pretty wide bridges to gap, just philosophically and approach-wise, between our fields. So
yeah, well, one example that we were talking about earlier is, let's say you're a nurse on a ward.
Mm-hmm.
Let's say you're on a med-surg ward, and something is happening. There's a violent patient. Something's going on. Maybe they have mental illness. Maybe they don't. So what they might do is pick up the phone and just call either security or 911 and say, "There's a problem. Come.
Yeah, get over here.
Get over here."
Yeah.
Is that the right way to do that?
Yeah, and the police tell us no. This is beyond my expertise. So I'm just kind of like kicking this, downstream from the police. But they say things like that happen. I've made calls like that, working on units, and I think like this is awesome. I've done the right thing, and here they'll burst through the door, but they don't know what's happening. And their training is that you don't walk into a door until you understand what's happening. So an example that they gave in a situation like that is designate somebody to stay on the phone, and then designate somebody else to be handling the situation. And the person stays on the phone, and then they'll be asking lots of questions. We get frustrated because we hear a 911 operator asking all these detailed questions, and we're like, dude, just get over here.
Yeah.
But what they're doing is they're typing away frantically, and they're actually feeding the information live to the officers as the officers are responding. So again, like that's a really good example of just I don't know the context. I don't know. I'm making assumptions about you're not responding. You're asking me all these dumb questions, and then here what's actually happening, unbeknownst to me, is the response that I want.
Yeah. And you showed me some video about San Francisco Police Department training and different things like that. And I mean, there's a lot of interesting and important work going on behind the scenes to sort of train officers in this sort of response. Do you think these guys are pretty good over here at doing it now?
I think they can get good at it. I think a lot of them are. I think a lot of them are good at it. I think the ones that come through and do it, we've shown in some of our research, we can get change in knowledge, we can get change in attitudes, we can get change in referral behaviors. CIT is a nationally kind of packaged response to
what does CIT
training.
stand for?
So
for people who don't know?
crisis incident team training is a kind of a national model of how we can enhance police officer response to health and mental health care emergencies and crises. And these systems can prove effective. And then we're getting so effective at those, and those are pretty well dug in now and have a good foothold. And so we're getting kind of a critical mass of attitude shift and skill enhancement with the police officers. And then now they are saying, okay, now a bottleneck is happening because I want to take somebody to psych hospital. I recognize this as a psych issue. It's sub-threshold for arresting somebody, but I don't have a bed.
Yeah.
Or this one place in town that's designated themselves a receiving center for police doesn't have a bed open. So.
And this appears to be a recurring motive in the comments. It's like
Oh,
we
yeah.
just aren't funding the outpatient spots for treatment, the inpatient beds, none of this. Now, here's an interesting comment from Diane Stiegel. I was violently assaulted at gunpoint by a 17-year-old. Typical broken home situation. Mom's in jail, dad's out of the picture, teenage father. Showed no remorse. Do you believe he was treatable, or because of his social situation, his violent behavior, was it an inevitable expression of rage, grasping at control to feel empowered? He's now a registered sex offender.
Yeah, I mean, this is the big mystery, right? I mean, like, the unfortunate reality of post-traumatic stress disorder, and I was naive about this when I first started getting into this. The unfortunate reality is it's not just you're walking through life and then, boom, there's a trauma, and then after that, you're post-traumatic. Mm-hmm. You know, what we see in a lot of these folks, especially, you know, the way that I sample folks and the way that I see them is I'm seeing these folks who are getting wrapped up in these legal issues. By the time you're getting wrapped up in these legal issues and becoming of interest to me, I'm seeing long histories of the stuff that, you know, maybe you're alluding to here of what's going on in there. And I think the case illustrates a really important struggle here is, you know, I think a lot of my guess is a lot of your viewers would really struggle to say that that's someone that we should have a soft response on, and that's someone that we actually should have a hard response on, regardless of what the history may be.
I guess, yeah, and a question is, could that violent assault have ultimately been prevented through a different approach from the beginning to the end? Not for you, Diane, not putting that on you, but saying before that now this guy is criminalized, he's a registered sex offender, and we put him down a path that's going to be very, very tough. Yeah. And of course, what kind of support did Diane get now? Like, did her administration support her? Clearly, you know, he was prosecuted, hopefully, and all of that. But it's tough, and this has been a big problem with my tribe. They are they feel very vulnerable. They feel left apart from this. It's been kind of swept under the rug. And then you have the other side of it, like, well, who's committing some of this stuff when it's mental health? Is this preventable stuff? You know. Yeah.
And the answer, to some degree, is not by that point. So what it's going to feel like to us, and we work with the police officers on this, is these things aren't intervenable. By the time it's one of these crazy YouTube videos and somebody's popping out of a car and shooting somebody, or it's one of you guys getting assaulted, the system has failed, right? Like it's already failed by that point. Mm-hmm. So some of the issue that we try to get folks to realize is, you know, that one that comes in and you could discharge them right now, but you have that like sneaky feeling that they've got some mental health stuff going on. That's when it's a point where we actually can still screen for something and intervene upon it. That's when we can fix this cycle, because it's absolutely a self-feeding cycle that these folks get into. It's not fixable by that point.
Well, you know what? We're going to go to a little break right now, 15 seconds to fund the show, and also we're part of a Facebook beta that I want to keep giving them data for ad breaks, so it's going to give you a weird targeted ad. Meanwhile, Chris and I are going to confer, and then we're going to come back and take your comments. So we're going to do this, and... Hi, we're back. Bucolic background, real. I have Dr. Chris Weaver, PhD, forensic psychologist here in Palo Alto at Palo Alto University. He's a researcher, a teacher, and works closely with law enforcement in particular about how do we de-escalate, prevent violence, and criminalization of mental health, which leads people down a path to often ruin and puts us as healthcare providers in danger. So let's take some comments here. Let's see. If there's anything you see that pops out at you, feel free. Okay, Mary Marty, and I read these kind of in real time. I'm not really screening them. I'm going to say something that many don't want to hear. I like that already. Working as a psych nurse practitioner, I notice many MDs treat patients with mental health issues differently. Some act like they're dealing with the plague. So this is a stigmatization issue. So how do we begin to work with that? Is it better training for healthcare people? Is it public health programs?
Yeah.
You're dealing with officers a lot of the times. Do they have this stigma? In other words, are they treating these people differently than your standard garden variety?
Yeah. You know, it's interesting. So we've done our I've been doing work with them pretty intensively for the past decade or so. And, you know, when we used to kind of talk about or package our training and our approach, as kind of a mental health sensitivity issue, we wouldn't get a whole lot of interest in this. And then when we started to train folks and say, like, this is related to military veterans, and it's related to post-traumatic stress disorder, and that's actually a topic that will resonate with them. So, it never fails, but I'm going down through my criteria and describing what post-traumatic stress disorder is about, and you could see the eyes in the room start to go. Mm-hmm. So, it's something that resonates with any first responder, and probably, I would imagine, most of the ER folks out there. You will not be a stranger if you get on and start reading the diagnostic criteria and things for post-traumatic stress disorder. But most of us who deal with that kind of stuff in a day-to-day way have a way to kind of wrap it up and move on. And it doesn't mean that the effects of it, aren't there. So
Alex Peck asks a great question. What sort of support do the officers receive for their own mental health issues?
Yeah.
75% of their marriages end in divorce, according to Alex. These matters must be related.
Yeah, I mean, the stress for this is just tremendous. I mean, we ask folks to do it. It's not unlike what we're asking, a lot of your crowd to go do, in ERs.
Nurses, doctors, pharmacists, respiratory therapists, yeah.
So, it's hard. It's stuff that used to be stigmatized a lot. One of the things I think about the national conversations that are putting stress on police, and that stuff is stressful. And it's also stressing their command staff to do things like support mental health care support. So San Francisco's got a system where after a critical incident, somebody can come in and get counseling from somebody who specializes in working with police officers. And there's no ramifications, very little recordings of it, and so they can come in and get their services and kind of de-escalate themselves, right? Because that's what we're ultimately talking about. Mm-hmm. So it's something that needs to change. You're absolutely right. You're hitting on something that's critical, and I would say maybe almost as critical for your folks as it is for them.
You've done a lot of work in de-escalation. Have you also worked with hostage de-escalation and those kind of things, and those more?
Those are different kind of subfields. I've definitely had rooms full of hostage negotiators and working with those kind of folks, and this content resonates with them every bit as much. Different systems work in different ways. The way that some of the systems here locally, the way that they work is if the officers are going to be working with a certain situation for longer than 20, 30 minutes, and they can anticipate that, their job is to call the hostage negotiation folks and to get them on site, and they pull back, start to assess the situation, start to think about what they're seeing is behaviorally in the person, and think about that. So I see that maybe as a next stage of things is going into these specialized folks. But it's a struggle to figure out how do we get this stuff out to the police, the average police officer who's going to probably be the one who shows up, versus these specialized police officers who may be way across town when something goes down.
Mm. And again, it all starts with that 911 call. How you give the officers information if there's violence going on in the ward or whatever. It matters, and it's gonna make the difference in minutes and seconds with how they respond. Leslie Fullerton Passes asks, are you able to speak to the UCSF San Francisco General Hospital wraparound program? It's fascinating.
I don't know that program specifically. I don't know that one. It sounds like I don't know.
Yeah, no worries. I hadn't heard of it either. Could Dr. Weaver give us a few basic pointers on de-escalation, says Erica Christine.
Yeah, what I'm going to do too is I'm going to give you another link if Z-Dog can spare the real estate on his place here. So
I got nothing but space.
One of the things I've worked on is a partnership with the National Center for PTSD, and they put together a lot of what they call toolkits. And these toolkits they're aimed at different populations. I co-authored one with my friends over there, specifically targeted for police officers. And in that toolkit, there are a couple of our de-escalation techniques. That tactical transparency thing, the good dentist thing, that's one of the ones. We have a grounding technique on there, and we have just a couple of other stuff about body language and posture and things like that. So that's on that toolkit. I'll give you guys that link. If you follow that back, there are also all kinds of other toolkits. So there are toolkits for people who work on college campuses, or toolkits for folks who work in clergy. So there are toolkits for different folks in there. And to be honest, they're all worth kind of combing through and seeing what you can get in there.
Is there anything you could give verbally? Let's say, I'll just give an example, and if not, that makes sense too if you have to kind of go through a particular protocol. But there's a patient who's getting increasingly agitated in the emergency department. He's a big guy. He's there with his family kind of egging him on, saying maybe you should get the scan now. They're making you wait for the scan, and they haven't brought your sandwich yet. And you still have pain. He still has pain, and they're kind of and he's like, I still have pain, and getting kind of in the nurse's face. What are some things you can start to do?
Yeah, I mean, I think big things are, here's the model in which we kind of see this thing happening is there's a situation, and folks start to perceive some kind of problem. And the problem here is the pain and the lack of attendance or the lack of immediacy of the attendance.
That
right?
turkey sandwich.
Yeah.
Where's my turkey sandwich?
And so
I hit the call
yeah.
like 5 minutes ago.
Yes.
Right? So this is common.
Really? Yeah. So what you watch for, or what we see when we see violent incidences happen, we go back and deconstruct those, and there's always this kind of initial sense of I'm not getting something that I'm owed. But then there's also this kind of critical moment that we call a breach, and the breach happens right before we see this incident. So to some degree, your job is to try to kind of figure out, okay, who are my folks that are amping up? Who's out there in like this ain't fair to me land? And as you see that,
every one of the staff. Sorry.
Yeah, okay, so try to whittle it down a little bit farther. But, as you see it out there and folks start to develop or talk about this, or you see in the things that they're communicating that there's this theme of like, hey, you all aren't attending to me. And then being soft around any kind of thing that would be a breach, if that's even doable. And then being ready if you have to do something. Like I imagine there are times too where folks are agitated and you've got to do an intervention or something, right? So that could be coming there. But really, what we see as a big de-escalator is making a personal contact with somebody if you can. So we'll even train the police officers, hey, if somebody's agitating on you, you may be the stimulus that's pissing them off right now. Flip, with your partner. So send somebody else in. It's good cop, bad cop, right? And you guys can good cop, bad cop as well as anybody can. So flip it, send in another person and see if they can do nothing but just develop the rapport and see what they can do. And
this again, that's great advice. The tricky part is in healthcare how we're staffed. There may not be another nurse. There's one nurse for 5 people.
You guys are just sitting there waiting for work to do.
Of course, because we're just we're playing Angry Birds.
Yeah.
Going, when are the patients coming? I see he knew it. So it all makes sense. So again, we want to kind of push a little bit on administration and say, look, if you want a profitable, happy, healthy workforce, you need to provide reasonable staffing. You need this kind of training. Like I didn't know the term breach. I didn't know that. How do you then recognize that somebody is starting to pre-breach? Sounds like OB. But it's actually, something that then you can identify. And I like this idea of like swapping out. We've done that. We've done that on our ward teams. Maybe it's time to send in the medical student instead of the resident that's really triggering this patient. And the patient feels is not listening and not paying attention.
Or doesn't like that they're a student, or does like that they're a student. Who knows what it is, right?
It's always something.
Something. And with PTSD, you get fed into this notion of triggers, and anything can be a trigger. So if you've got somebody that's at risk for that kind of history, then you really amped up the number of things that can be setting somebody off.
Let me ask. Speaking of that, so we recently posted a meme on Instagram that was kind of a joke. I went to a restaurant in Half Moon Bay, and they had a sign that said, "We love pets as much as the next guy. But emotional support dogs are not service animals."
I know that sign.
You know that sign?
I do.
In Mezzaluna. And I tagged it and I made a joke about my neurosis support pug Paco. Don't you dare try to keep him from having his pasta. And it's interesting. There was a lot of comments from people who were very triggered by this. And
it's less funny when it's a military vet who's got his PTSD dog.
That's the thing. Now, what I didn't realize is that PTSD dogs are not considered, or are they considered service animals?
That's going to be a jurisdictional thing. So that's going to be just something that just happens to be in there. It's probably just another case of the law just doesn't keep up with how fast we're trying to push these things, right?
Yeah.
We can fix this stuff faster than the law is going to step up to it and right things. Yeah. So that's a good thing in some ways, but this is probably allows for loopholes like that.
And what an interesting thing, because it didn't occur to me that a vet with a PTSD support animal would not be considered necessarily by law service, but it's not. It's emotional support. And here's the thing: so the question is societally, if we want to allow a vet to integrate back into society and they have PTSD and the dog helps them, should the dog by law be allowed to come into the restaurant?
Yeah.
Just the same as a service animal for someone who's blind or another similarly disabled.
And is there a line at which we're willing to say, like, okay, we're all stressed and you can't bring a dog in just because you have stress?
And that's the other thing.
Yeah.
So that's where the joke I thought was funny to a lot of people, because they're like, yes, everybody's got a stress dog.
Yeah,
Like,
for sure.
what if I bring in my stress alpaca? Or my, my emotional support. I had Vader posted on his page,
Yeah.
Doc Vader, and
It's got to be a stressful job.
So it's a stressful job being a Dark Lord of the Sith. Every day is stress. So he wanted to bring his emotional.
Nobody appreciates what you do.
You know what? Here's the thing about Vader. All right, and I'm getting a little triggered right now.
Tell me about
because I know a little bit about Vader. I just get in his head, literally. And Vader goes around the galaxy. He's snuffing out Jedi scum, right? Like he was taught to do by the Emperor. And nobody appreciates him. It's always like,
hard.
Jedi lives matter. And he's like, Sith lives matter. Like, this is a thing for me. And the problem is he wants to bring his emotional support Rancor into the cantina.
I say let him.
And they're like, Rancors are dangerous and they eat people and they destroy droids. And he's like, but this is the only way I can come in here without losing my shit. So, I mean, these are real.
Let him eat the occasional pig guard. It's okay.
By the way, how sad was it when the guard, when the Rancor died, and the guard was like, ah, 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 ah.
He looked oddly like Phil Collins. You know he did.
You know he did, because he felt it coming in the air tonight. Let's read some more comments, and then we'll... I think handing out service dog certs for everything someone wants is crazy, says Tammy Hamill. It's making it difficult for people who could benefit from the program from doing so. So this is the thing. So you got a kid who just wants their dog, and they're like, well, this is and you can't legally ask about a service animal, right? Like, that's I think that was one of the things. It's like in some jurisdictions you cannot ask, what is that dog for? So they got the little vest, the kid's holding the dog. It's like, well, what can the restaurant owner do? And so then it just devalues people who actually need the dog. So that's where the joke was aimed, actually, is not at people with legitimate service dog or emotional support dog needs.
If everybody has an emotional support dog, then nobody has an emotional support dog, right?
Bingo.
So that's
Bingo.
It's a tough thing to try to figure out.
Yeah, and it's also a funny meme. So that restaurant has mice, rats, and roaches, but won't allow a dog. Jacqueline Pevney.
Yeah, but some killer fish tacos.
Those
man.
tacos are dope.
Yeah.
So, all right. That all being said, Chris, was there anything else you thought was very important for the Z-Pack to know? And we can always bring you back.
Yeah, I mean, we can come back if we want. There's a model that we use in the work that we do in looking at decriminalizing mental illness. It's called Sequential Intercept Model. I'll throw a link up on there of that too. You can see on there where we start thinking about this at the mental health care system and how that feeds all the way in through the legal system. But I want you guys to think about this too, because to me, what we need laid over top of that mental health system is probably the healthcare system. And you guys are probably an important funnel down to or into the mental health care stuff. And then screen those folks. I'm going to try to give you some tools to help do that, because when you screen them and you know that they are there and you know that you need different staffing ratios for that, now all of a sudden you've got data to make a different argument about staffing ratios, and then hopefully we can tackle this stuff. I want to keep working to keep having law enforcement folks bringing more folks into you, so I want all of us to be working together to make that a safe proposition.
And we were talking about this before, like Chris's sort of mission is decriminalizing mental health, putting them in the right setting. And unfortunately for us, we are so overwhelmed, but the right setting may well be us in mental health.
Yeah.
So and so many comments about how do we increase
do it,
that? Well, until we identify this is the problem, here's a solution, more mental health.
Yeah.
And that's going to offload our jails. And that's going to prevent further criminalization. It's going to offload our criminal justice system and our courts, and in net save money. Then maybe that's a good use of federal money.
Yeah.
Right.
And the reason we're dealing with this now is because the last couple of generations, since this deinstitutionalization stuff started back in the '60s, kicked it down to us. So what are we going to do, folks? We're going to fix this now and not kick it down to our people, or are we going to just roll it on down the stream?
Well,
so that's the decision.
You and I know what's probably going to happen, but we're going to make the opposite happen.
We're going to bitch about it.
We're going to bitch about it the whole time as the world falls apart. No, that's not what the Z-Pack does, son. The Z-Pack is here to fix things, to build Health 3.0, and I think this is part of the conversation we have to have. Anyways, guys, so if you want to reach out to Chris, message me. I can connect you guys. Is there any other resources that you would?
No, they can find me through the Palo Alto University website if you want to do that. Email and everything, phone and everything's up on there, so give me a shout. and we'll get those links up and should be good. But folks, ask for whatever you want.
That's perfect. That's nice to make yourself available. And we out, man. Peace.